should be. John, are you on? Can you see everything?
We can do it.
Well, you don't have to make a black sheep PowerPoint for yourself.
No, Lauren's in town by herself.
Oh.
And so
She's in town now? Okay.
I thought.
How are you?
Good.
Yeah.
Or we need to
What-
get her
what-
phone number or something.
When dinner?
Okay.
Yeah, I
Should
don't
be good.
What?
Okay.
What day?
Well, I was
Hold on,
actually
Bill.
going to ask JJ because he was so
And I'm
JJ?
narrowing
Okay,
down.
ready?
Right.
You're right there.
So, welcome to our second session of our BCOP review on pediatric oncology, and we have like one of the best lecturers that I've ever heard. One of them, Sarah Lenz, is another one. Also true. It's true. Vicki Nussbaum is a pediatric pharmacist, and she's been a pediatric hem-onc pharmacist for a while. We won't go into how many years. She's board certified in oncology pharmacy for both adult and peds, and has worked on different peds committees nationally, setting therapy and research goals.
Okay, so this is based on the 2014 review. I got the one for 2015. I see they have a new author, so there's a few changes. They've added supportive care and survivorship, so as you study, that's not included in this part of the lecture, but that, go ahead.
So we did get the 2015 BCOP review materials, and they're posted, and I'll send out links to them later.
Okay. So we'll start with ALL because that's the most common pediatric cancer by far. And our numbers don't come close to the numbers of adult patients. So this is the most common one, and there's 2,400 cases per year in the U.S. And mostly it's ALL, 20% is AML. The peak incidence is like 2 to 3 years of age, so it's the little kids, and the cause is unknown. In the pathophysiology, it's due to blasts or immature white blood cells replacing normal bone marrow, and then it's divided into T cell and B cell ALL. You look at the CBC and differential at presentation, and the white blood cell is normal to low in most of the children, and they have a normochromic normocytic anemia, and they usually have thrombocytopenia. And the signs and symptoms of leukemia, they can have fever, bleeding or bruising, bone pain, and the little kids, they usually limp or they go back from ambulating to wanting to be carried. They can have lymphadenopathy and hepatosplenomegaly. And for diagnosis, they need a bone marrow aspirate and biopsy. And if at least 25% of the lymphoid cells in the bone marrow are blasts, the patient has ALL. And the treatment, first you have to deal with tumor lysis issues. So you have to hydrate the patient. And in pediatrics, we call maintenance fluids 1,500 mils per meter squared per day. And then for hydrating, you give 1.5 to 2 times this rate. And then we used to alkalinize with sodium bicarb in the IV fluids, but this has fallen out of favor. It was thought that it kept uric acid in solution, but it hasn't been shown to be that helpful, so we don't do that anymore. And the drugs we use, we've got allopurinol, we've got rasburicase for if the uric acid is above 10, or if their creatinine is elevated, or their white blood cell is greater than 100,000. And we kind of have an at-a-glance method for evaluating creatinine. So if their creatinine, if you just look at a child and a normal kid who's up to 2 years of age, their creatinine should be like 0.2. And then you add 0.1 milligram per deciliter per year until they get to be 8 years of age. And then their creatinine levels are about the same as an adult. So that's how you can just glance at a kid as you're monitoring and see if they're okay or if they're in trouble. And ALL induction lasts about 4 weeks. For standard risk, it's called 3-drug. They don't count the intrathecal. And the high risk is 4-drug besides the intrathecal. The high risk kids are the kids who are less than 1 year of age, those who are greater than 9 years of age, and those presenting with a white count above 50,000, those with T-cell ALL, and then with certain chromosomal translocations. And the babies who are less than 1 year of age, they do so poorly that they have their own protocols. They don't even lump them in with the other kids. The 3-drug regimen includes a steroid, either prednisone or dexamethasone, then vincristine, and then some form of asparaginase. Now it's just PEG asparaginase or Erwinia, and then IT methotrexate every week for 2 to 4 weeks. And then the number of doses that are given and the amount depends on the amount of leukemia cells in the CNS, so whether they're CNS positive or CNS negative. And then intrathecal dosing is age-based, not body size-based. And they usually get intrathecal cytarabine on their day of the diagnostic lumbar puncture. So their first day, they get their intrathecal cytarabine. And then the 3-drug regimen is prednisone, it's 40 milligrams per meter squared per day, or dexamethasone, 6 milligrams per meter squared per day, and they do that for 28 days. And then they get vincristine, 1.5 milligrams per meter squared IV every week for 4 weeks, and it still maxes at 2 milligrams. And then they get the PEG asparaginase, 2,500 units per meter squared IM for 1 dose. The intrathecal methotrexate is based on age, with a max of about 15 milligrams for kids who are greater than or equal to 9 years of age. And then this is just an example of what it looks like for how they split up the ages. And then for the high-risk kids with the 4-drug regimen, they use the same 3-drug regimen, plus they add in daunorubicin, 25 milligrams per meter squared on days 2, 8, and plus or minus 15. And then if daunorubicin is used, then the steroid has to be prednisone, because the combination of daunorubicin and dexamethasone posed a greater risk of fungal infections. And then, depending on the protocol, they'll pick a day that they're going to do a bone marrow aspiration, so they'll do it at either day 7 or 14, and then at day 28. And if you're in remission on earlier, it's associated with an improved survival. And then they'll look at minimum residual disease, and they'll test the blood or bone marrow to predict your chance of relapse and to define your future treatment. So they'll look at your minimal residual disease at that point, and that determines which arm of the study you'll go on from there. In post-remission therapy, which is also called consolidation or delayed intensification, it begins only if the patient is in remission after induction. And then this is an intensive chemo after induction, and it has proven to help prevent relapse. And the best regimen hasn't been determined yet. The duration is like 25 to 50 weeks, and the intensity and the duration is based on the minimum residual disease. So the chemo they get in this period includes methotrexate, 1 gram per meter squared every 3 weeks for 6 doses. And then they can also do escalating doses of methotrexate plus the PEG asparaginase. They can do cyclophosphamide, 1 gram per meter squared, followed by cytarabine, 75 milligrams per meter squared, either sub-Q or IV for 10 days, with thioguanine for 14 days. And then vincristine and pred pulses, doxorubicin, and then varying doses of asparaginase, which has kind of been narrowed down now due to the lack of asparaginase. And then the high-risk kids get more aggressive treatment for longer duration, and their regimens include high-dose methotrexate of 5 grams per meter squared and higher dose of asparaginase, which they're using the PEG, 2,500 units per meter squared, just because of the lack of asparaginase. And then maintenance therapy. Without maintenance therapy, most of the kids with ALL will relapse, because you can still have undetectable disease after induction and consolidation, which is classified as minimal residual disease. And then maintenance chemotherapy is methotrexate. It's 20 milligrams per meter squared It's by mouth once a week for 1.5 to 2 years, and mercaptopurine 50 to 75 milligrams per meter squared per day for 1.5 to 2 years. And then the doses are adjusted up or down by 25% to keep their neutrophil count between 500 and 1500. And then they'll get periodic intrathecal methotrexate and vincristine plus 7 days pred or dex pulses. And if they relapse, it's usually in the CNS, and they can treat it with cranial radiation, reinduction, reconsolidation, and then maintenance. And then if it's a bone marrow relapse, if they relapse on therapy or within 1 year post-chemo completion, doing a bone marrow transplant is a better option than doing more chemo. Their chance of second remission is good, but long-term survival is not so good. It's often less than 50%. And radiation, they do use cranial radiation in kids with T-cell ALL, and the main use is for CNS relapse. It does cause growth deficiency if you're using craniospinal radiation, and it does cause IQ declines. And then for prognosis with ALL, it's pretty good. It has about an 85 to 90% long-term survival. The kids in the age range of 1 to 9 have the best outlook. An initial white count of less than 50 is the best. Minimal residual disease, if it's detected, is bad, and it's used to tailor your post-remission therapy. That's relatively new, using that. And then the DNA index, hyperdiploid is favorable, and that's like extra copies of chromosomes, like trisomy 4, 10, or 17, have a lower risk of relapse. And then the unfavorable ones include the Philadelphia chromosome, MLL rearrangements, and then there's a favorable one called tau AML1. And then early response with bone marrow remission on day 7 or 14 is favorable. This time he didn't include much on AML. The most effective regimen is daunorubicin or idarubicin plus cytarabine. And this cytarabine is 3 grams per meter squared. IV over 3 hours, every 12 hours for 6 doses. And then it alternates the next course at 100 milligrams per meter squared per day, continuous infusion for 7 days. And then daunorubicin 45 to 60 milligrams IV daily for 2 to 3 days per course, which is pretty similar to the adults. And the course is repeated for 4 to 6 months. So as opposed to ALL, which gets prolonged, not so toxic chemo, AML gets short-term, pretty toxic chemo. And the main issue with AML is severe bone marrow suppression, nausea and vomiting, and mucositis. And these patients usually have to stay in the hospital for several weeks after chemo to get their counts to recover. And most relapses with AML are in the bone marrow as opposed to ALL, which tends to be a CNS relapse. And CNS therapy in AML is controversial, but most use intrathecal cytarabine every 2 to 3 months. And maintenance therapy has not been shown to improve survival with AML, so that's why they don't have that prolonged therapy like ALL does. So with AML, after your induction, you have consolidation if you're using different agents compared to induction, or intensification if you're using the same agents but at higher doses. And if the patient has a living related donor who matches them, they go to transplant once they're in complete remission. The prognosis with AML is nowhere near as good as ALL. They have about a 50% long-term survival. It improves to about 60% with a transplant from a living related donor. And some subtypes have a more favorable prognosis. And bone marrow blasts that are above 5% at day 15 and having a minimal residual disease of 1% or more after your first induction are bad prognostic indicators. Once again, the age less than 1 and a white cell count of above 20,000 have the worst prognosis, and the 3 to 10-year-olds have the best prognosis. And late effects with ALL and AML, anthracycline cardiotoxicity is a problem because if the kids live long enough, they can end up having heart failure. You can get secondary AML for the ALL patients who got the epiphytophyllotoxins. And then you can have decreased bone mineral density with the steroids and leukoencephalopathy with methotrexate. Now, pediatric CNS tumors, go ahead.
Just have a quick question. So for pediatric patients, every pediatric patient that has AML will go to bone marrow transplant, or are they risk stratified?
They're risk stratified.
Okay.
The low risk get chemo,
Okay.
the higher risk ones go to transplant.
And is it just if they have a matched related donor?
No.
No,
It
so
would.
don't look
They
for it.
will look for a. They will look for a donor.
Unrelated.
Yeah. So CNS disease, CNS tumors, they kind of clump them together. So there's about 2,200 cases per year, and as a group, they're the second most common childhood cancer. They're also more of the younger kids, and males have more disease than females. There's 3 main types based on incidence, and as a group, they account for 2/3 of the pediatric brain tumors. They include medulloblastoma, astrocytoma, and brainstem gliomas. And medulloblastoma is one of the primitive neuroectodermal tumors. The median age at diagnosis is 5 to 6 years. It arises in the cerebellum, and 25 to 45% will have leptomeningeal mets at diagnosis. It's rapidly growing, so they'll have a short duration of symptoms before they're diagnosed. And then signs and symptoms, they'll have signs and symptoms of increased ICP or intracranial pressure. They'll have headaches that are usually worse in the morning. They'll have emesis, lethargy. They can have hydrocephalus. Later on, they can have ataxia, double vision, weakness, and then papilledema and strabismus. Staging. Favorable disease includes kids who are older than 3 years of age, the localized disease that has complete or near total resection, and then high risk is invasive disease that limits the total resection that can be achieved. Having more than 1.5 square centimeters of residual disease or having overt metastatic disease like subarachnoid seeding is high risk. So you can't have very much tumor left over post-op to have a high-risk diagnosis. And then at diagnosis, there's a high rate of dissemination with subarachnoid seeding in 20 to 30% of kids. And then there's this chain classification with a T stage and an M stage. The T stage doesn't have any prognostic value, but the higher the M stage, the less chance of survival. And then treatment, surgery is the most critical, and you have to have almost a near complete resection to have any benefit. And you can do a post-op MRI to detect residual disease and then go back for a second surgery to decrease the amount of residual disease. And you can do bone marrow aspirate and biopsy, and 5% will have systemic mets. Radiation. Post-op cranial spinal irradiation is curative in about half of the patients, but immature brain tissue is very sensitive to radiation, so it's avoided during the first 2 years of life and, if possible, up to the first 5 years of life. Attempts to prevent and reduce the effects of radiation include dose reduction of the radiation from 36 to 23.4 gray for standard risk patients when combined with chemo. They've tried hyperfractionating radiation to see if it's less toxic. They've tried using chemo to decrease the dose of radiation or avoid it altogether. And the inability to give radiation to younger kids has hurt their chance of survival. It's kind of chicken soup chemo. They do get a lot of different agents, and the one protocol that we use, the Head Start, they do use all this. And the chemo is used to avoid radiation in very young kids, and it can be used with radiation to decrease the dose of radiation, and it's unclear if chemo improves survival in the low-risk patients. Here's an example of a CVP chemo. They use vincristine, lomustine, and pred. And here's a Philadelphia regimen with cisplatin, lomustine, and vincristine. And then for transplant, high-dose chemo with an auto transplant has been tried in kids who are less than 2 to try to delay or avoid radiation. And the best outcome is still if you can get the surgical resection. The most important prognostic factors for medulloblastoma are the metastatic stage, the adjuvant treatment, and how much residual tumor you've got. So 60 to 80% survival based on how aggressive the surgery was, as well as the chemo and radiation. Poor risk kids are those less than 3 years of age, those with subarachnoid seeding, greater than 1.5 centimeters squared of tumor remaining post-op. Depends on their histology, their DNA content, and c-MYC amplification, and if they've got deletion of 17p. And then their morbidity, their physical and psychological sequelae are significant, and it does likely exceed that of other pediatric malignancies. They take a significant hit from their chemo and radiation and surgery. Astrocytomas are the more slow growing or low grade, and about 20% are malignant. Those are the anaplastic astrocytoma and glioblastoma. There's 2 histologic types of cerebellar astrocytomas. They're juvenile pilocytic astrocytomas and diffuse astrocytomas. The signs and symptoms are pretty similar. They're increased ICP, seizures, visual disturbances, and it can be similar to medulloblastoma. It depends on their location. Treatment is surgical. Cerebellar astrocytomas, you can cure them surgically. Low-grade astrocytoma is primarily a surgical disease. With malignant astrocytoma and glioblastoma, the goal is maximal resection. For radiation here, you still need to avoid it in kids less than 5 years of age, if you can. And it helps prolong the time to tumor progression if there was an incomplete resection of the malignant astrocytoma or glioblastoma. Chemo here is also multi-agent, and there's a whole list of chemo there. Carbo is used in most regimens because it's among the most effective. Chemo is used where radiation was deferred or where it's failed or where surgery is not a good option. So here's an example of a regimen with carboplatin, vincristine, and the dose difference of vincristine if the child is small. And then we're looking at temozolomide and angiogenesis inhibitors investigationally. Right now, the worst prognosis is malignant astrocytoma and glioblastoma. And the extent of resection is important for cerebellar gliomas. Recurrence of low-grade tumors treated with surgery or local radiation. And the older the patient, the worse the prognosis. So brainstem gliomas, these most frequently occur between 5 and 10 years of age, so they're a little older kids. They usually occur in the pons, but it can be in the medulla or the midbrain. It rarely causes an increase in ICP until later in the course. And you usually have extraocular muscle paresis or double vision, facial weakness, cranial nerve dysfunction, personality changes, and spastic gait or hemiparesis. And there's two categories. There's diffuse infiltrative and focal. And then treatment, you do surgery to remove as much as possible while you're still trying to preserve neurologic function. And then radiation is the mainstay of treatment for diffuse infiltrative, but it's also used for palliation and for control of neurologic symptoms. And then chemo is used with radiation, but there's no survival advantage with diffuse infiltrative disease. And diffuse infiltrative disease does not have a good prognosis. Its median survival is poor, and focal has a good prognosis if it can be removed surgically, and survival is 50 to 100%. So neuroblastoma is the area where things have changed a little in the last year. So there's only about 650 cases in the U.S. per year. It's also in the younger kids. The median age at diagnosis is about 22 months of age, so they're little kids. It's not known what the cause is. There's deletions or rearrangements on the short arm of chromosome 1 or 17, the most common cytogenetic abnormalities. And for infants, a DNA index above 1 is associated with a lower stage disease, and a DNA index of 1 is predictive of advanced disease. And deletions at 1p or 11q are also associated with a poor prognosis. NMYC is an oncogene on chromosome 2, and multiple copies of this are associated with advanced stage disease and a poor prognosis. An NMYC amplification is intrinsic to the tumor, so if you don't have it to begin with, you don't develop it later on. It's just it is or it isn't. And about 25% of patients have NMYC amplification. So this arises in the adrenal medulla or paraspinal sites where sympathetic nervous tissue is present. It is a small blue round cell tumor like Ewing sarcoma or non-Hodgkin's lymphoma, primitive neuroectodermal tumors, and rhabdomyosarcoma. 65% are abdominal and 20% are thoracic, and it spreads to lymph nodes, bone marrow, bone, liver, and skin. They thought that they could screen urine for this by looking for catecholamines, but it doesn't reduce mortality, and it's not recommended because they ended up picking up the kids with favorable biologic features, but not the kids who had unfavorable advanced disease, which are the ones that you need to worry about anyway. So biologically favorable neuroblastoma does not progress to unfavorable neuroblastoma. So this usually shows up as an abdominal mass. It's either adrenal or paraspinal, and 70% have metastatic disease at diagnosis. 40% of the kids have low to intermediate risk disease, which is cured by surgery or surgery plus chemo, and 60% of the kids have high risk disease, and these kids rarely survive even with conventional therapy. So they look at urine catecholamines. The VMA and HVA are elevated in about 85% of the kids. And the higher the VMA to HVA ratio, the better the prognosis. And then they look at neuron-specific enolase, and it's elevated in 95% of patients who have widespread disease. Ferritin is produced by neuroblastoma cells, and it's elevated in 50% of patients with stage 3 and 4 disease. So they'll get an abdominal x-ray, and then the mass displaces but doesn't invade the kidneys, so that's one way they can tell it from Wilms tumor. And they'll get a skeletal series. You can see lytic lesions in the ribs, vertebrae, orbits, and skull. They get an MIBG scan, which is very sensitive for neuroblastoma, and that is just the nucleotide that they give to them, the marker, and it's taken up directly by the neuroblast, and then they do a CT of the chest, abdomen, and pelvis. And then there's a staging system, which is stage 1 through 4, and they have also a 4S, which doesn't fit into the scheme of higher number equals worse prognosis. 4S is a localized primary tumor with dissemination limited to the skin, liver, or bone marrow, and it's limited to infants less than 1 year of age. It's usually hyperdiploid without NMIC amplification, and most kids are stage 3 or 4. So the risk group is based on age, stage, and tumor biology. Low risk is not treated unless life organ impacting tumor. Intermediate risk, they get chemo, surgery, but not radiation. High risk, they get everything. Chemo, surgery, transplant, radiation, cisretinoic acid. Now, treatment options. Surgical resection can cure localized disease. It's also used for debulking tumors. Radiation is not useful for disseminated disease, even though neuroblastoma is radiosensitive. Chemo is used in all but stage 1 and 4S disease. And then there's just a list of the chemo that's been used. The older kids don't respond well and are less likely to be cured. The biologic response modifiers are used after the stem cell transplant. They use differentiating agents like retinoic acid. They use MIBG to target radiotherapy for metastatic neuroblastoma. And then they use this anti-GD2 ganglioside, CH1418 monoclonal antibody. So treatment by stage. So stage 1, complete resection, negative nodes, surgery cures about 90%. If they're NMIC positive, some people would still say they need chemo because the NMIC puts them at risk. Stage 2A, the infant 2B and 3 get surgery. If they're NMIC positive, the chemo, or if they've recurred, they get chemo. Chemo includes cyclophosphamide and doxorubicin. Failures will get cisplatin and etoposide. You can use radiation for residual disease after a second look surgery. And here's an example of the chemo for a stage 2A infant, 2B, or 3. They get cyclophosphamide, doxorubicin, and you repeat every 3 weeks for 5 courses. And then a stage 2B with positive nodes, only a 50 to 70% cure rate, so we're not doing very good there. They get surgery, chemo, and maybe radiation. So they get vincristine, cisplatin, and etoposide, alternating with vincristine, cyclophosphamide, etoposide, and carboplatin. Stage 4 is unfortunately where most of the patients are. It's the least responsive to chemo. Survival depends strongly on how old they are. And even with aggressive treatment, survival rates are usually no better than 20%. High risk is stage 4, and now they may include stage 2, 3, 4S kids who have NMIC amplification. So treatment includes aggressive induction chemo, then they get consolidation with intensive chemo or high-dose chemo, total body irradiation, and a transplant. The stem cell transplant can be allo if there's a matched SIB, or auto. They're about the same success. And then infants with stage 4 who are not NMIC amplified get much less aggressive course, and they respond to moderately intensive chemo. And then 4S, the course is determined by their age and the liver involvement at diagnosis. NMIC amplification is treated as high risk, but a surgical resection can be curative. You can have spontaneous resolution, so this is really kind of a bizarre disease. It can, if it's a bad setup, you can pretty much die no matter what we do, but it can also spontaneously resolve. It's very strange, like this stage 4S can spontaneously resolve. And for spinal involvement, chemo alone is the safest, most effective treatment. And then chemo for stage 4, they get cyclophosphamide, doxorubicin, and vincristine alternating with cisplatin and etoposide. They also get retinoic acid, which helps the neuroblastoma cells differentiate, and then monoclonal antibodies to the neuroblastoma antigens. And infants with stage 4 respond to less aggressive courses than the older kids. And then this drug was just approved by the FDA. It's a monoclonal antibody that targets GD2. We knew it as CH1418. And GD2 is a glycolipid that's overexpressed on the surface of neuroblastoma cells. And the dinutuximab binds to this GD2 and induces a complement-dependent and antibody-dependent cell-mediated cytotoxicity. The FDA approved it for treating the high-risk neuroblastoma in pediatric patients who achieved at least a partial response with prior first-line multi-agent, multimodal therapy. And it's used in combination with GM-CSF, interleukin-2, and 13-cis-retinoic acid. The dose is 17.5 milligrams per meter squared per day over 10 to 20 hours, depending on how well they're tolerating it, for 4 consecutive days for a minimum of 5 cycles. So you start it at a low rate for 30 minutes, and then you gradually increase as they tolerate it up to the maximum rate listed at 1.75 milligram per meter squared per hour. The side effect, these are the most common ones that are grade 3 or 4 toxicity. Neuropathic pain is a big one, and that usually is what makes you have to slow down the rate. They can have fever, usually it's just fever, not neutropenia. Infection, hypokalemia, hypersensitivity reactions, hyponatremia, increased liver labs, and hypotension. The kids that I've seen mostly have trouble with pain and hypotension, and then we just have to extend the interval on how long we infuse it over. And sometimes we've had to just give up and not give it.
So do you do anything else, any other supportive care for the pain?
The pain, we do morphine or dilaudid PCAs. We've got lidocaine drips going.
Wow.
So it's involved.
It's pretty significant.
It is. It's significant pain. Yeah. It's not an outpatient treatment. No. And then you can interrupt the infusion, you can reduce the rate of infusion, you can dose reduce, you can discontinue the treatment. We pre-med with analgesics, including opioids. We pre-med them with antihistamines, things for fever, and then we hydrate them for the hypotension. And then for the stage 4S, the clinical course depends on their age and their liver involvement when they're diagnosed. If they're NMIC amplified, we treat them as high risk, and then surgical resection will cure most of the 4S kids. The 5-year survival for infants is about 90%, and it's about 55% for the older children. Age less than 1 year is most important factor for favorable outcome, with survival rates above 95%. And the 5-year disease-free survival for kids with stage 4 is only about 35%. So positive prognostic factors include hyperdiploidy, your pathology, your normal NMIC copy number, low LDH, low ferritin, high VMA to HVA ratio, having neuron-specific enolase less than 100, and expression of HA-RAS P21 or TRK gene. Wilms tumor. This is a kidney tumor, and it's due to a loss of a function of a tumor suppressor gene. There's only about 500 cases per year in the U.S. It peaks at 2 to 3 years of age, and it's very rare after 6 years of age. There's sporadic and familial types, and the familial types tend to be bilateral and occur at younger ages. It's usually detected by the caregiver who notices an abdominal mass, and only about 25% have hypertension. The favorable pathology, in about 85%, it's well differentiating and it resembles developing embryonic tissue. Unfavorable histopathology is anaplastic, clear cell, or rhabdoid. And they can spread locally to infiltrate the renal capsule, involve the renal sinus, or tumor in the intrarenal vessels, and then they can spread distantly to the lungs, the regional lymph nodes, and the liver. Now, neuroblastoma will displace the kidney, but Wilms tumor distorts the kidney on scans, so you can kind of tell which one you're looking at on the scans. And they use ultrasound to check for thrombus in the renal veins and the inferior vena cava, because the stage is increased if the thrombus is attached to the vessel walls. Plus, when you're doing surgery, you do not want to spill this thing into the abdomen, so they want to know where it is. And you can have, for symptoms, you can have abdominal pain, and you can have microscopic or gross hematuria. And then the staging depends on how extensive it is, whether it's extended beyond the kidney or not, and how, whether it's bilateral or not. The treatment, surgery is the most important. They'll look at the involved kidney, but they'll also look at the other kidney to be sure that that one isn't involved too. And if it seems like it's really a large tumor, they can use chemo first to shrink the tumor, or if they want to get it to shrink out of the vena cava to get it down to where they can safely get it out of the kid, they'll do that first. And then radiation, if nodes are involved, or metastatic disease, or if they're peritoneal seeding, or if they spilled it during surgery or the tumor ruptured, they may have to do radiation. So they don't want anybody to do abdominal exams on the kids because of the chance of rupturing the tumor. And if pulmonary radiation is used for METs, the doses of the chemo dactinomycin and doxorubicin should be held during the radiation and reduced 50% for 4 to 6 weeks after radiation to decrease the risk of the radiation recall. And then chemotherapy, we use vincristine, dactinomycin, doxorubicin, and cyclophosphamide. They're the most active. And then for converting between one meter squared and per kilogram doses, they say a kid who's about a meter squared would weigh 30 kilograms, and you use that as your conversion factor. And then sometimes for kids who are less than 1 year old, they'll cut the dose in half after they've converted it to a milligram per kilogram to reduce the toxicity even further, and then increase to see how they tolerate it. So this is an example of what it looks like. It's dactinomycin, 0.045 milligrams per kilogram per dose, and it starts within 5 days of their nephrectomy, and then they get it at week 3, 6, 9, 12, 15, and 18. And then vincristine, 0.05 milligrams per kilogram on the same, on day 7 after nephrectomy. And then usually it's weekly for 10 doses. And then no radiation for that stage 1 and 2. And then 3, 4, go ahead.
Have you ever seen anything more than one tumor in one kidney, or just always, is it always in one?
We have seen it in more than one. And I've seen it in a kid who's had it in one, and then later it happened in the other one. So, yeah, it's variable. Yes. Yeah, because then they end up on dialysis. So this is the higher stage where they get dactinomycin, doxorubicin, and vincristine, and then they get radiation to where the tumor was. And then the unfavorable histology, they'll get radiation, doxorubicin, vincristine, etoposide, and cyclophosphamide. And then for the rhabdoid tumors, they're investigating high-dose carbo and etoposide alternating with cyclophosphamide, along with surgery and radiation. And then prognosis-wise, this one isn't so bad. Based on stage and histology, stage 1 survival is almost 100%. And Stage 5, it's like 75% 4-year survival. The unfavorable histology is about 55%. And histology is the most important prognostic factor, with distant mets and lymph node involvement being important also. Now, rhabdomyosarcoma can occur anywhere. The usual sites are GU, extremity, head, neck, trunk, orbit, retroperitoneum, and prostate. We've had some 4-year-olds with prostatic rhabdo. There's 4 types. They're embryonal, alveolar, undifferentiated, and botryoid. The embryonal resembles striated muscle, and it's seen in younger kids with head and neck or genitourinary. And then alveolar resembles lung cells, and it's seen more in the older kids, and it involves the trunk and the extremities. And it spreads locally via lymph nodes or blood, and the primary sites for metastases are regional lymph nodes, lungs, blood, and bone marrow. The lung is the most common. And treatment, surgery, if it's in a place where you can resect it. Chemo, most of the kids would relapse without chemo, as this is a systemic disease. And radiation, they can use it for local control. Here you have to hold actinomycin if it's being used. And it's used for alveolar and undifferentiated tumors regardless of what stage they are. So the chemo they use is vincristine, actinomycin, and cyclophosphamide. And for group 1, localized with complete resection, they'll use vincristine and actinomycin for a year with no radiation. For group 2, with microscopic residual disease and maybe lymph node involvement, they'll use radiation with chemo, and they get 90% local control, and they use that vincristine and dactino for a year with radiation. Group 3, they can pulse vincristine, dactinomycin, and cyclophosphamide for a year with radiation. And group 4, the metastatic disease, they'll pulse the VAC alternating with ifosfamide for a year plus radiation, plus etoposide. And prognosis, overall, it's 70% long-term survival. The most important variable is your clinical group or the extent of disease at diagnosis. The second most important is the primary site. Histology is also of prognostic significance, and the best to the worst is the botryoid, then embryonal, then alveolar, and then undifferentiated. And without completely obliterating the tumor, the cure is not possible. And transplant doesn't seem to improve survival in the high-risk patients. And late effects in these kids, they tend to have hemorrhagic cystitis, infertility, cardiomyopathy, abdominal adhesions, secondary malignancies secondary to radiation, like radiation-related sarcomas and secondary AML, and renal Fanconi syndrome with ifosfamide. And retinoblastoma is pretty rare. There's only 300 cases in the U.S. per year. 75% of cases are unilateral. The majority are in very young kids, 95% before 5 years. And the RB, or retinoblastoma gene, is a tumor suppressor gene, and it gets inactivated. There's 2 types. There's hereditary and there's sporadic. Kids with a positive family history will get eye exams shortly after birth, and then at 6 weeks of age, and then every 2 to 3 months until they're 2 years old, and every 4 months until they're 3 years old. And this is one of the very few pediatric cancers that you can screen for. And the signs and symptoms, leukocoria is like a lack of a red reflex in their eye. So it looks like they have a white pupil, and they can have strabismus or red painful eyes. It arises in the retina, and it can spread locally or distantly. And local spread is growth into the intraocular space. And metastatic disease occurs when the tumor grows along the optic nerve, and it spreads to the CNS, or it can spread via lymph or blood. In diagnosis and staging, you can do an eye exam with an ophthalmoscope, ultrasound, a CT, and that staging is based on the number and size of tumors and whether or not there is vitreous seeding. Treatment surgery includes enucleation for advanced disease. It's not done as much as it used to be. They try to save the eye if they possibly can. Radiation, they can try to use that to control the disease and retain the eye and useful vision. It does give you an increased risk of second cancers. Chemo, they can use IV and IT chemo if there's metastatic disease present. They can use it to minimize the need for radiation or enucleation. And they use vincristine, etoposide, carboplatin, and combination chemo and radiation is used in stage 4 and 5. And they can use laser photocoagulation or cryotherapy if the tumor is small enough that they can get to it and just do it topically. And most of the kids with retinoblastoma will survive, but the patients with the germinal mutation tend to get a second non-ocular malignancy like osteogenic sarcoma. And I've only seen one kid with this, and they actually did get osteosarcoma later in life. And retaining vision depends on the size of the tumor and where it is in their eye. Osteosarcoma, there's only 400 cases per year in the U.S. It's mostly seen in adolescents during the growth spurt, and it's a high-grade sarcoma. It usually occurs in the distal femur, the proximal tibia, or the proximal humerus. It's most common in the distal femur. It can also involve flat bones like the pelvis. Risk factors include bone diseases like osteogenesis imperfecta and Paget's disease, but that usually is in the elderly where it causes osteosarcoma. Ionizing radiation can be a risk factor, genetic predisposition like retinoblastoma, and then the risk of the secondary osteosarcoma there, and alkylating agents, but mostly they don't know why it happens in these kids. So signs and symptoms are pain, mass, or swelling over the involved area, and about 20 to 25% will present with metastatic disease, which is mostly to the lungs. The diagnostic tests include x-rays, CT or MRI, biopsy, and you can see an increased ALK phos and LDH. There's staging. Stage 1 is low grade, 2 is high grade, most of them are high grade, and 3 is you have distant mets. For treatment, surgery, you can remove the primary tumor for durable local control. You can do limb salvage or amputation. You have to use chemo also, or most patients will have recurrent disease. And metastatic disease must be completely removed in order to get a cure. Osteosarcoma is not radiosensitive, so radiation is not used. And this is a difference compared to Ewing's sarcoma because Ewing's is radiosensitive. And with surgery alone, 80% of patients with osteosarcoma will recur and develop metastatic disease. Osteosarcoma is relatively drug resistant due to peak glycoprotein, and few drugs are effective. We use a lot of high-dose methotrexate alternating with doxorubicin and cisplatin. So they get cisplatin 120 milligrams per meter squared over 4 hours, doxorubicin on days 1 and 2, and 1, 2, and 3 as a continuous infusion or as a bolus. And then alternate that with methotrexate 12 grams per meter squared over 4 hours. And then we use leucovorin rescue with that. And the max methotrexate dose is 20 grams. And we use neoadjuvant chemo. You give the chemo for a few cycles, and then you assess the tumor response at the time you resect the tumor. And less than 90 to 95% tumor necrosis is associated with poor risk disease. And shrinking the tumor with chemo prior to surgery improves the chances of limb salvage compared to amputation. And overall, neoadjuvant chemo hasn't improved outcome compared to post-surgical chemo.
So you don't do that, right? Unless you have to. You don't do that?
We do, because you still want to. They still want to look at the tumor kill. They still use that as a marker of how well they're going to do.
So even if there's really not much chance of limb salvage, they'll still try to at least use the chemo neoadjuvantly just to kind of see what
Their
how the tumor
prognosis
responds.
is, yeah. And then surgery and adjuvant chemo have a 50 to 75% disease-free survival at 2 to 5 years. Clinical characteristics of prognostic significance include the extent of disease at diagnosis, which is most important, and having overt metastatic disease will have a poor outcome. Axial primaries, like the pelvic disease, will have a worse outcome. And age less than 10 years is worse, and older than 20 is better. Females have a better outcome, and increased levels of ALK-Phos are associated with increased risk of metastatic disease and a worse prognosis. Ewing sarcoma only has about 200 cases per year in the U.S. It's most commonly seen in adolescents also. It's considered a bone tumor, but it can come from soft tissue. It's a primitive neuroectodermal cell tumor, a small round blue cell tumor, and it has a unique translocation of 11 and 22, among others. And osteosarcoma is usually in the long bones in the extremities, while Ewing's is usually in the axial skeleton. And the most frequent sites are the pelvis, but the humerus and the femur can also be involved, but it can also occur in any bone. Signs and symptoms include pain and swelling at the affected area. Patients with metastatic disease can have signs and symptoms like fatigue, anorexia, weight loss, and fevers. And there can be just an extraosseous tumor with no bone involvement. Without systemic treatment, over 90% of the patients will develop mets, mostly to the lungs. It can also spread to other bones and bone marrow. It's highly malignant. There's no universally accepted staging system. The presence of metastatic disease is the most important issue, and elevated LDH is associated with metastatic disease and a poor prognosis. Spread to the lymph nodes is rare as opposed to rhabdo, osteo, and pnet, which often involve lymph nodes. And CNS spread is rare. Mets to the paraspinal area are common. Surgery is used for local control. You can use surgery or radiation for local control. Neoadjuvant chemo is given to assess tumor responsiveness and to treat micrometastatic disease. Neoadjuvant chemo can improve resectability of the tumor, and you can do limb sparing and amputation here also. And Ewing sarcoma is very radiosensitive, and you use radiation for lesions that are difficult to remove surgically. And radiation can be used if surgery would result in a loss of nerve function. And radiation doses above 60 gray are associated with secondary sarcomas. Chemotherapy, they traditionally use vincristine, doxo, cyclophosphamide, and dactino. And ifosfamide, etoposide alternated with vincristine, doxorubicin, cyclophosphamide, and dactinomycin has been used. And there's vincristine and doxocyclophosphamide alternating with ifosfamide and etoposide. That's more like what we're seeing now. In transplant, patients with multifocal or metastatic disease at diagnosis have a very poor prognosis, and high-dose chemo with transplant is frontline therapy for these people. And the most important prognostic factor is the extent of disease at diagnosis. Increased LDH predicts metastatic disease and a poor prognosis. Mets to the bone marrow or bone is a poor prognostic factor. Multifocal disease at presentation has a bad prognostic factor. And patient less than 10 have a better outlook than older patients. Distal sites are more favorable. Unfavorable sites include pelvis, sacral lesions, and intermediate sites include humerus, femur, and rib. The overall survival for a distal extremity is 60 to 70%, and pelvic is only 35%. And then the size of the tumor affects outcome also. Pathologic response to neoadjuvant chemo will, like, if you have a good response, and that is a good prognostic sign, same as with osteosarcoma. And that is the end. And good luck on the exam. And did we make it within 1 hour? We did. Do you have any questions? Thank you. I don't think there was that much.
Okay.
It was more,
Like knowing the type of chemo that they're using.
yes,
Yeah.
that sort of thing,
And how she
or,
pulled out that, like if you had an osteopenia and they were using radiation.
yes,
That could be the
yeah,
wrong thing, or you had Ewing's and they picked do this, and there's no radiation in it, you know it's wrong.
Okay.
yeah.
I think there were a couple questions on my test about like what drugs you use for like rhabdo or, and it's, they kind of listed the drugs.
And I remember there was toxicity too.
Yeah.
What drug was it? Was your therapy partially developed?
I'm
That's a
pretty
toxicity question.
I'm pretty sure that new drug is gonna be on the fall and spring test.
The one for
coming year.
neuroblastoma.
Yeah.
Yeah.
Okay.
I'm pretty sure.
Okay.
Not that I was at a question writing
Right, no.
at all.
Not there.
But I'm pretty sure that you may see a question on that.
All right.
Thanks, Vicki.
Thank you.
Thank you, Vicki.
Thank you. Good audience. Thank you.
Big topic to cover.